heard about the background and rationale, but I would like to emphasize it again. It is very important to realize that the benefit of revascularization is highest in patients who have coronary stenosis that are hemodynamically significant. And there's evidence for SPECT showing that this has a major impact. And of course, there's evidence for invasively measured FFR, as we know from the FAME trial. And if you look at the COURAGE trial, there's also evidence that revascularizing lesions without doing these tests has no major advantage over aggressive medical therapy. Now, when it comes to CT perfusion, there have been some studies done so far. Most of them are with 64-slice CT scanners, many of them also from Dr. Lima's institution, but the evidence is still limited. So this is really the first large prospective study looking at this. Now, what do the guidelines say? If we look at the most recent ESC, EACTS guidelines for myocardial revascularization, of course, this test is not in total, but parts of it are. So we have to remember that in general, non-invasive testing before angiography is probably most appropriate when we look at an intermediate subset with intermediate likelihood of coronary disease or of obstructive disease, I should say. And if we look at MDCT angiography is currently a class 2A/B indication. If we look at nuclear imaging, meaning SPECT, it's a class 1A indication here. And of course, CT perfusion studies are not contained in this type of recommendation yet. I wouldn't be surprised if they will be contained in the next ones. So as you heard, this was a large study for this type of study with 391 patients. It was a multi-center study and multinational studies, and it was prospective. And it was a non-invasive CT evaluation of coronary artery disease lesion severity and hemodynamic significance on a per patient and on a per vessel basis. And the comparison was made to invasive angiography plus SPECT. As you heard, the CT study were actually two studies, and it's important to remember that. First, there was a REST CT angiography combined with CT perfusion, and 10 minutes later, there was an adenosine stress CT perfusion study. Combined CT angiography and perfusion studies were found to be superior to CT angiography alone, and correctly identified flow-limiting and functionally relevant obstructive coronary disease, and also predicted revascularization with an accuracy similar to invasive coronary angiography plus SPECT. So it basically was shown to be equivalent to this. And I'm just showing one of the results slides again, because although this was not an outcome study, this is the closest that there is to clinical impact. And you can see that the CT angiography plus perfusion study was comparable to invasive angiography plus SPECT to predict revascularization on a 30-day basis. Nevertheless, I think the results are very straightforward and elegantly documented. There are a lot of open issues that remain and which will probably be answered in the course of the next years. The first question is, of course, who should have this test? Will this change the practice of having non-invasive tests prior to invasive angiography in any way? Who should go directly to invasive angiography based on clinical information? I mean, do we need this kind of test in a patient who has classical angina and is highly symptomatic and has ST depressions on treadmill testing, etc.? What is the role of CT perfusion versus invasive FFR measurements at the time of angiography? In other words, will this add something, or do we just take the patient for angiography if the patient is symptomatic, and we do FFR testing using the pressure wire technology? Where do those things come together? We also have to remember, as Dr. Lima already pointed out, that stress CTP is an additional study after CT angiography and requires additional radiation and contrast administration. This may be particularly an issue when you use not a state-of-the-art 320 slice CT scanner, but something that is much more widely available, such as a 64 slice CT scanner. This is really done at the expense of a substantial increase in the radiation dose. So finally, there are some concerns and considerations we have to still think about. One of them is we have to remember there is an exposure to radiation, there is an administration of contrast, and it has to be justified within the clinical picture. And we also have to think of the cost effectiveness of this procedure and look at patient benefit. Thank you.